The topic of my presentation today is Theories of Depression, and my moderator is Dr. Mohan Dhyani sir. So, in this presentation, we'll be covering the biological theories and the psychological theories of depression. The psychological theories of depression, we'll be just touching upon them. And since there are a lot of biological theories to be covered, we'll be going through each theory very briefly. So, first of all, the biological theories of depression. So, what are the brain areas involved in depression? So, as we all know that in depression, everything is seen from a very negative perspective. All the memories are very negatively biased. So, we have here the amygdala and the hippocampus, which is involved. Then the dorsolateral prefrontal cortex. So, all the goal-directed activity, the spontaneous goal-directed activities are decreased. The concentration, the attention, they are compromised. And there is also decreased energization, that is loss of initiation or willpower to start any activity. The ventromedial prefrontal cortex is involved, and the orbitofrontal cortex, which has role in emotional regulation, and the anterior cingulate cortex is involved. Next, what are the main monoamines involved in depression? So there are basically three main monoamines, that is norepinephrine, serotonin, and dopamine, which are involved in depression. So let us come on to norepinephrine. So we know that the cell bodies of the noradrenergic neurons, they are located in the locus ceruleus of the brainstem, and from here they project to the whole cortex of the brain and to the limbic system also. So this norepinephrine, it has roles in limbic arousal and cortical arousal. Also, it is physically active. That is, increased activity is seen during when new stimuli are perceived, and decreased activity of this norepinephrine neurons are seen during eating or sleeping. Now, it has role in limbic arousal, cortical arousal, and via the median forebrain bundle, it innervates it, and it has roles in goal-directed and reward-seeking behavior. Also, there is abundant adrenergic innervation to the hippocampus and to the amygdala. Hence, it has roles in emotional memory and behavioral sensitization to stress. Also, during stages of prolonged stress, chronic stress, there is prolonged activation of locus ceruleus, which leads to a state of learned helplessness. Then serotonin, we know, the cell bodies of these neurons are present in the dorsal raphe nucleus of the brainstem, and it has roles in sleep, appetite, libido, body temperature, and metabolism. It also innervates the suprachiasmatic nucleus present in the hypothalamus and has roles in regulation of the circadian rhythms. Serotonin is known to physically suppress the REM sleep. Dopamine, we know the substantia nigra in the midbrain, and it is basically more implicated in schizophrenia, and we have the classic dopamine pathways, which we all are aware of. Next, let us come to the classical theory of depression. So, according to the classical theory of depression, by some unknown mechanism, there is depletion in the levels of monoamines, and depression is due to this deficiency of monoamine neurotransmission. That is, it is a chemical imbalance theory. So in this picture, we can see that here the monoamines are present in abundance. This is a normal state, and here there are decreased levels. But now, basically, we have just, if we are still living in that era of monoamines, we are outdated. So we have moved on from just the monoamines to the receptors and to the emotion, to the molecular events, and to the molecular events triggered by these receptors. Also, there is role of nature, nurture, and genetics, but we'll not be discussing genetics here. So according to this theory of monoamine receptor hypothesis, either there is no real monoamine deficit and there is an abnormality in the receptors, or there is decrease in the monoamines and there is a compensatory upregulation of the receptors. So this theory basically tries to explain that why even after when we give antidepressants and it leads to immediate elevation of the monoamines, why the clinical response is delayed? Because it takes time for the upregulated receptors to come back to their normal state. So here we can see the receptors are upregulated. Next is the glutamate hypothesis. So we know that glutamate is a excitatory neurotransmitter, and it basically binds to the NMDA, N-methyl D-aspartate receptors, which are present abundantly in the hippocampus. Now, we'll be studying further in the presentation that there is increased activity of the HPA axis in depression, which leads to hypercortisolemia, increased levels of cortisol. And this glutamate, in conjunction with hypercortisolemia, it basically leads to neuroinflammation. It has more neurotoxic effects. This has been seen. And sub-anesthetic doses of intravenous ketamine, which is a NMDA antagonist, it can exert rapid antidepressant effect lasting for around 3 to 7 days, but due to its psychomimetic and dissociative effects, ketamine is not used. Next is a very recent hypothesis, which has recently come into light, the leaky gut hypothesis. So basically, we know that our gut harbors trillions of fauna. It has fungi, bacteria, bacteriophages, and various other microorganisms. Now it is said that basically the gut is our second brain, the enteric nervous system. And gut basically, it affects our brain. It affects distal organs like the brain. And it has been seen in various studies that the use of prolonged antibiotics has led to depressive effects. So in this, according to this hypothesis, their MDD is associated with microbial dysbiosis, that is alteration in the microbial diversity owing to the disrupted balance of microbiota and corresponding functional changes. So what happens is the pro-inflammatory cytokine, the pro-inflammatory bacteria increase and the anti-inflammatory decrease. So there is enrichment of the genus Bacteroides and depletion of the genera Blottia, Faecalibacterium, and Coprococcus. Now it is unclear whether the microbial dysbiosis, it precedes depression or it is an effect of depression. So this basically becomes a vicious cycle. So here in this picture, we can see that these taxas of microorganisms are increased. Next is gut microbiota derived metabolites in depression. So what are these metabolites? These are basically the fermented food products. With the bacteria which ferments the products are known as metabolites, and also the bacterially modified host molecules like bile acids. So these metabolites are known as the microbial metabolome. So even when there is dysbiosis, the microorganisms are disrupted, so the metabolites are also disrupted. So short chain fatty acids are depleted in patients of MDD, while their administration has seen to be result in antidepressant effects. Also, neurotransmitters like GABA and serotonin produced by the gut microbiota directly or indirectly influence emotional behavior. Now, what is this this gut-brain axis? So let us try to see this diagram. So the gut and the brain axis, it is a bidirectional axis, and basically there are three main routes of this axis. First is the endocrine route, the immune route, and the nervous route. So this is the intestinal epithelium here, and here we can see the gut microbiota and the metabolites. So when this is disrupted, when there is dysbiosis here, there is inflammation of this epithelium of the intestine, and inflammation leads to increased permeability, that is leaky gut. So the gut becomes leaky, and the inflammatory biomarkers of like TNF alpha, interleukin 6, they lead to systemic inflammation, and they cross the blood-brain barrier, and here they lead to more neuroinflammation. So when neuroinflammation occurs here, there is increased activity of the HPA axis and increased cortisol levels, which further contributes to this. And the vagus nerve also, it has been seen that vagus nerve basically, it has role in the gut-brain axis in transmission of signals from the gut to the brain. And in one experiment which was carried out in rodents, it was seen that the subdiaphragmatic vagotomy led to decreased rates of depression in rodents. So next is the neuroplasticity and neuroprogression hypothesis. So BDNF, we know, brain-derived neurotrophic factor. It is a growth factor, and it has roles in neurogenesis and neuroplasticity. Now, stress, inflammation, and other genetic and environmental factors lead to loss of growth factors, leading to lack of synaptic maintenance, loss of synapses, dendritic arborization, and ultimately leading to loss of neurons themselves. So here we can see in this very simple diagram, there is no BDNF, the neurons are dying, and here they are progressing. Next is the stress diathesis model or the hypothalamus, pituitary, and adrenal axis dysregulation. So one hallmark of the mammalian stress response is increased HPA axis activity. Now, what can be the causes of this increased activity of the HPA axis? There can be increased drive from norepinephrine, acetylcholine, or cortisol releasing hormone, a decreased inhibitory serotonin tone, or a decreased feedback from amygdala and hippocampus. Now, amygdala and hippocampus, they normally suppress the HPA axis, but due to chronic stress, there is atrophy of these neurons in the amygdala and hippocampus, which leads to loss of the inhibitory control and hence more increase in the HPA axis. So increased HPA axis, which will lead to increased cortisol level, increased CRH, and increased cortisol levels will lead to increased levels of mineralocorticoids, glucocorticoids, which are released from adrenal gland, you all know. And glucocorticoids at high levels are toxic to neurons and contribute to their atrophy. So another test which was done was the dexamethasone suppression test. Normally, dexamethasone is a very potent glucocorticoid, and if it is given at night at the rate of 1 mg, it basically suppresses cortisol levels normally throughout the night. But in these patients of MDD, it has been seen that it fails to suppress the cortisol levels next morning. But this is not specific because increased cortisol levels are also seen in starvation and in dementia also. So it is not diagnostic, but it has prognostic values as non-suppressors have increased severity of depression and more relapse rates. So this is the HPA axis, we know about this. Then we have the hypothalamus, pituitary, thyroid axis dysregulation. So it has been seen that clinical hypothyroidism is frequently associated with depressive symptoms, and in treatment-resistant depressive patients, there is subclinical hypothyroidism. Studies suggest that clinical benefits of T3 as an augmentation agent with antidepressants in patients with major depression who have not responded to antidepressant monotherapy. Now, there is supraphysiological doses, role of supraphysiological doses of thyroxine in mood disorders. There are studies for this. So it has been seen that supraphysiological dose means more than 150 mcg per deciliter of levothyroxine. So it has efficacy in reducing the depressive symptoms in rapid cycling, prophylaxis resistant bipolar patients, and for patients with refractory unipolar or bipolar depression. But there are it is lacking in long-term studies, and also we know that increased levels of levothyroxine are a risk factor for developing osteoporosis, and it has cardiovascular risk like atrial fibrillation, high output cardiac failure, and systolic hypertension. Hence, it is not used. Next is the role of ovarian hormones. So ovarian hormones, we know they increase the release of monoamines. So in females during the last stage of the menstrual cycle, when there is increased progesterone and decreased estradiol levels, they experience affective symptoms, which is also known as the premenstrual dysphoric disorder, and also during menopause in the postpartum period, depressive features are seen. It is said it is likely due to this. Then oral contraceptives have been long linked to the potential to alter mood, but there is controversy that whether they worsen mood or improve mood. And one study showed that oral contraceptive use is associated with increased risk of subsequent antidepressant treatment, but studies are still lacking. Now the role of testicular hormones. So depressive symptoms are common in men referred with borderline testosterone levels, and middle-aged non-depressed men in community with low testosterone levels have a higher likelihood of developing depression. The bulk of evidence suggests that testosterone does not have efficacy in treatment-resistant major depression, but as an adjunct to antidepressants. So this is the axis, the hypothalamus pituitary gonadal axis. We can see here cholesterol is basically the raw material for the synthesis of dehydroepiandrosterone, testosterone, progesterone, and this is the female menstrual cycle. Now, broken circadian clock, it has roles in mood disorders. So it has been seen that there in mood disorders, there is flattening of the daily body temperature cycle. There is elevation of cortisol throughout the day, reduction in the levels of melatonin that normally peaks at night and in the dark. Also, there are certain genes implicated which are known as clock genes. So these clock genes, they operate in a circadian manner sensitive to dark light, and abnormalities in these clock genes have been linked to mood disorders. Now, what are the sleep disturbances seen in depression? So there is decreased total duration of sleep, increased nocturnal awakenings, increased core body temperature. The core body temperature normally falls at night, and increased temperature is seen here. Increased REM sleep and decreased slow wave sleep is seen. Also, there is reduced REM sleep latency. The time elapsed between the onset of sleep and the first REM stage. There is decreased REM sleep latency. Terminal insomnia and blunted growth hormone secretion. The growth hormone secretion, it peaks within 90 minutes of falling asleep. There is blunted growth hormone secretion. Also, it has been seen that there is, in these patients, there is increased blood flow to the limbic system and increased glucose metabolism. Next is role of inflammation. So mood disorders are associated with chronic low-grade systemic inflammation, and there are increased pro-inflammatory cytokines like the TNF-alpha interleukins, which normally regulate mood behavior and cognition by influencing neurotransmitter levels. And pro-inflammatory cytokines may even aggravate the short-term mood changes to a chronic maladaptive depressive state by preventing the normalization of mood after adverse life events. So these pro-inflammatory cytokines, they lead to decreased production of BDNF. We read this is a brain-derived growth which leads to decreased neurogenesis. And it also basically, there is this enzyme tetrahydrobiopertin, which is a key enzyme in the monoamine production. Now, increased oxidative stress may compromise the monoamine synthesis by depleting this. Also, there is increased enzymatic activity of indolamine 2,3 dioxygenase, leading to increased breakdown of tryptophan and hence decreased serotonin production. Now, the brain networks involved in depression. So we all know what are the brain networks: the salience network, default mode, cognitive control, and various others. So there are two main networks involved in depression: the default mode and the cognitive control network. So what is the default mode network? The default mode network is the network which is basically active during resting wakefulness. It is active during daydreaming, or it is active during autobiographical memory or self-referential thinking. So it has been seen that there is hyperconnectivity in depressive disorders in this default mode network, and this predisposes to negative recall and rumination. Next is the cognitive control network. Now, this network has role in control of affective arousal. It suppresses the negative effects along with the anterior cingulate cortex when novel problems are encountered, and the connectivity of this network is said to be diminished in depressive disorders, and it may also this lack of control of arousal, affective arousal, may lead to relapse in more rates of relapse and reoccurrences. Now let us move on to the psychological theories of depression very briefly. So first of all, we'll be discussing the cognitive theory, which was given by Aaron Timken Beck at the University of Pennsylvania. Now, according to him, depression results from specific cognitive distortions present in persons who are susceptible to depression. So these people, they have, according to him, they have a faulty way of thinking. They have a negative attributional style to negative attributional styles to everything in life. This has basically existed in forms of latent mental schemata, which has been altered by the childhood experiences. We'll be studying this further. So there is depressive schema all around in this patient. So this is the model. So according to this, so basically there are certain core beliefs or schemata which are present in a person. So these are basically present because of childhood abuse or neglect by the parents, or when bullying. So these schemata are formed, or core beliefs are formed, but they lie latent. So when a certain situation, like a person faces any similar situation, so these schemata, they become active and they influence the content of thought and the process of thinking. So basically, according to Aaron T. Beck, the emotions of people, their behaviors is determined by the way they interpret the events in their life. So he gave the cognitive triad, that is negative views about the world, future, and negative views about oneself. For example, someone, I failed in my academic test, so I'll be like, I am not worthy of pursuing MD, or I'll never be able to, this is a very difficult course, I'll never be able to pass MD examination, or everyone think of me that I am a failure, I do not deserve to live. So there is this cognitive triad. Also, there are cognitive distortions. These are faulty ways of thinking. These include, so these are the cognitive distortions mentioned here. So first of all, for example, we have overgeneralization, forming conclusions based on too little or too narrow experience. For example, I failed in one exam, I'll not be able to pass any of the exams. Then personalization, tendency to self-refer. For example, this is seen in parents. Like parents tend to say like there is some the child commits any mistake, that it is their fault, it is their fault in their upbringing, they personalize it to themselves. Or there is specific abstraction, focusing on a single detail while ignoring the other. For example, if one person is sleeping in the class, the teacher might think that he is not teaching very well, even though the others are very attentive and they are understanding, but he'll just focus on that one particular thing. There is magnification and minimization, that is overemphasizing your shortcomings and undervaluing your achievements. Then dichotomous thinking, either this or that, all or none. Then next is the Albert Ellis ABC model of depression. So according to Albert Ellis, good mental health is the product of rational thinking and depression is the product of irrational thinking. So he gave this ABC model. A is the activating event, B is belief, and C is consequence. For example, I was walking by the corridor and I waved at a friend. Now the friend did not wave back at me. This was an activating event. Now I may believe that the friend, maybe she was busy and she did not look at me, or I may believe or I may think irrationally that she is ignoring me. So the consequence can be a rational thinking. I'll go and speak to her that whether if something is bothering her, or irrational thinking. I'll never speak to her again. I will even delete her number. I'll never talk to her again. So this is the consequence. So it is based on good, rational and irrational thinking. Next is the learned helplessness model. So Martin Seligman and Mayer at the University of Pennsylvania gave this model. So according to them, depressive posture is learned from past situations in which person was unable to terminate an undesirable event. So what they did was they took 3 groups of dogs. So the first group, they put the dogs into a cage, but they were allowed to escape. No shock was given to the dogs. In the second group, the dogs they were put into a cage and an electric shock was given to them, but there was an escape mechanism. For example, there was a lever, which was, when it was pressed by the dogs, they could escape from the cage. Now the third group of dogs, they were put into a cage with no escape mechanism and they were given electric shocks. Now what they did was they put all these 3 groups together in a cage where electric shock was given, but there was an escape mechanism. So what was seen was that the first 2 group of dogs who had a way to escape in the past also, they escaped. But the third group of dogs, even though there was an escape mechanism, they did not even try to escape. Basically, they had learned to be helpless, that nothing can help them now. So this was the learned helplessness model. They were shown how the other dogs. Yes, ma'am. Still they did not escape. So Martin Seligman postulated that a trait of learned helplessness, a belief that it is futile to initiate personal action, to reverse the aversive circumstances formed from the accumulation of past episodes of learned helplessness. So similarly, in this diagram, we can see that a baby elephant is tied to a log of wood. He cannot escape that. He cannot break this chain. But when the elephant grows up and the size is comparatively so large to the log of wood that he can easily escape, but he does not even try to escape. So the last one is the reinforcement model by Peter Lewinson. So according to this model, a low rate of rewards or receipt of response in contingent rewards. So contingent means temporal correlationship between a behavior and its consequence. The behavior should follow by a reward for reinforcement to occur. So either there is a low rate of reward or there is a response of incontingent rewards, which constitutes a critical antecedent for the occurrence of depression. So it is said, so according to him, the behavior of depressed persons does not lead to positive reinforcement to a degree sufficient to maintain their behavior. Hence, depressed people find it difficult to initiate or maintain their behavior and they increasingly become passive. So the experience of little or no rewarding interaction with the environment causes the person to feel sad and blue. Now, the reasons for this can be that there is lack of availability of the rewards, positive enforcers in the environment, or the person may even lack skills. He does not even have the skills to obtain positive reinforcers, or the negative impact of punishing events is heightened than the potential rewards. These are my references. Thank you.
So, anybody have any question?
Model. So Aaron T. Beck, he gave this cognitive model. So according to him, so for example, there is a child and the child has repeated bullying in childhood, there is parental neglect. So the child may think that I am not worthy enough, I am not good enough, I am ugly, I am not intelligent, and he may form this mental schemata, this core belief in his mind. But it may lie latent until he is exposed to a similar situation in life, and these thoughts they become active. And this the activation of this latent schemata, it basically results in a faulty process of thinking of this patient, which we talk as the cognitive distortion.
Is the reverse, like if somebody goes to a cafe and his order is not served, like somebody else is served before, so he feels that I'm a failure. So that thought actually is going through a lot of processes. So there is a core belief that I am a failure or I'm not good, people don't like me. And because of that, he is thinking that there can be, for example, the stimulus is that he has been served late. So there can be n number of thoughts. So one thought takes precedence over all the other thoughts. The automatic thoughts that are generated, that is the first thought that comes to mind. That is the first thought that comes to the person's mind is that I'm a failure. Why does that first thought come into mind, not the other thoughts? Is because of this automatic thought. Why it comes? Because there are some attitude and then core belief. So this core belief that he is engaging everything with that core beliefs. So the thoughts align with that. So this only affirms this. See, I'm here also. I'm being look. Nobody likes me. So that is how. So you have to. That is how CBT also works in the beliefs. So we have to identify the core beliefs. And the person may not even know that I have these beliefs that I'm a failure or nobody likes me. He just feels that I am being not served and he feels sad. So you have to ask him what are you thinking, and he will say that I was not served. I did not like it. So if you question further, then you will be able to find out why actually he felt sad, so sad at a very basic event that he was overlooked in a restaurant, he was served later. Why would somebody feel sad? The sad is because his basic belief that nobody likes me is being say coming into the consciousness. The second thing which is of the cognitive model is that the moods don't work in isolation. Okay. So whenever somebody is feeling something, there is a thought behind that. Right? So somebody is feeling that I'm feeling sad. They just feel the sadness. There is a thought behind that. So a person can, so how do you identify? You can say the patient can say that I went to a cafe, I sat there and I was very gloomy. So he wouldn't even know that this thing is going on. If you question what happened, why were you gloomy suddenly in a cafe, maybe they will then be bringing to their consciousness that yeah, I was gloomy because I was served it. So then you ask, well, why would such a small thing like you were served second was it to be sad? Because that I thought maybe they were overlooking me or like they didn't like me. And that goes to the core belief that nobody likes me. Okay, so the person will just feel that he is like he sees everything in the environment and he feels sad. You have to find out these things. These things are these core beliefs are the ones that are actually working the thought process, and then automatic thoughts that come to the mind are the first thoughts that make you start. Actually, Dr. Rasta was to do more on biological things, which we just touched upon. The topic given to unpack biological, psychological theories is a different topic. But that is why I have struck to cut down on these only these things on that. So if you have any more questions about biological theories, psychological, I think we'll have a detailed seminar later. These are things that we need to go into the psychological theories of it. Can you please go back to that exam?
Subsequent test. Yes.
You can understand that sometimes it is not obvious. Although it like in 90s and 2000, a lot of research is done on this. There are a lot of cases also lost. This is a turning point in the sort that for the first time or during this period, people started to think of depression in a biological, not purely psychological, like bereavement, okay, and response like that, purely psychological. So this is because the DST or this kind of theories, they started with these are starting point of depression being considered as a not purely psychological. So it has a these tests have like at one time people thought that maybe they can devise a test by which they can diagnose depression. Unfortunately, DST does have a correlation with depressed mood, but it is not specific. And it is say not safe also because you have to disturb it.
So,
Yes, yeah.
so the dexamethasone suppression test. So dexamethasone is a glucocorticoid, and we know that if glucocorticoids are given exogenously, so via a negative feedback mechanism to the brain, it will suppress the endogenous cortisol levels. So what was seen that in depressed patients, when dexamethasone was given at night at 1 mg, at the rate 1 mg, so it failed to suppress the cortisol levels the next morning. Otherwise, basically, it should have suppressed in normal individuals, but it failed to suppress. So this showed that there are increased levels of cortisol in depressed patients, but it was not specific because increased cortisol levels are also seen in situations like starvation or sleep disturbances or dementia. So it was not specific, but it had a good prognostic value.
What did they measure next day? What
Cortisol levels.
Cortisol level.
Yes, sir.
So it did not decrease.
No, sir. It didn't.
One of the things is that you are saying that noradrenaline is a stimulant and it helps in reward,
Yes, sir.
but also chronic
Stress.
stress,
Yes.
chronic noradrenaline. Actually, it causes. So that's the thing. You see, we have a negative feedback mechanism. So after a time, that suppresses the brain's. What it states is that the negative feedback mechanism is not there. Although there is enough stressful, enough cortisol out there, even then it is not suppressing. So noradrenaline also it pushes somebody. Like if you see panic attacks, history to take history of panic attack. After panic attack, most of the patients will report of exhaustion, tiredness because all the adrenaline is burnt out. So that is burnt out, so they will complain of tiredness and not willing to do anything. Okay, so that follows the panic attack. That anxiety easily, but that fatigue remains. And if there is chronic stress, so this negative feedback stops working, and brain keeps on producing, irrespective of any stimulating or disturbing event. It keeps on producing that cortisol. That biochemistry keeps on happening. So comments from there, please. Right. So there have been studies of anti-inflammatory uh, medications to reduce depressive symptoms. Okay. There are also reports of people getting down to painkillers. Okay. So that is also true. Why they are not approved? Can you throw some light on that? Concepts or anti-inflammatory. At the end of the day, it is safety and efficacy. So any medication should have safety as well as efficacy. So they should be safer than the current medication. So we measure, compare the safety compared to the existing medication. So prolonged using some tox inhibitors given for long period. They have little
Effects on the renal effect, renal side effects.
comments. Okay. Okay. So vitamin D, how? Shed more light on that. What about sunlight, light? Yes. So that is also there, that when the days are short, the day the symptoms increase. Okay. Vitamin D again is found, there is association, but there is a difference between association and correlation. So can it be vice versa that patient with depression have lower vitamin D?
It can, because the patient with depression may not go out and
Yes.
just stay indoors.
Poor appetite, okay, less intake, not having vitamin. So we need actually to predict causation. That is a difficult task. But yes, there is an association, and malnutrition actually is very common in depression. Vitamin deficiency, iron deficiency also. Vitamin deficiency is also like L-methyl folate is also one of the vitamins that is found deficient. There is association of lot of this. What is hyperthyroidism? Yes, supra.
So, supraphysiological levels of levothyroxine. So there have been basically many studies to see that whether these like supraphysiological doses of levothyroxine can help in mood disorders, and it was seen that they were efficient in reducing the depressive symptoms and in reducing rapid cycling, but they were not approved because of the
What
side
is
effects.
in normal patients or hypothyroid? Okay. So thyroid is a hormone that is to give to somebody who is not having hypothyroidism. 150 mcg can
Crisis.
be needed. Okay, it can trigger arrhythmia. That is the main thing. Can trigger arrhythmia because it increases heart rate and it can cause atrial fibrillation. So we can never give 150 mcg a normal patient. So even in when you potentiate augment 25 to 50 mcg because that is the required daily dose that is okay. That is our body is producing that much amount on this day. So you give that is not good. People who have hypothyroidism require more than that. Okay. So you measure the TSH. All right. And you keep the TSH below 1 without any symptoms of hyperthyroidism. So you have to check the pulse, you have to see that these symptoms are not there. All right. Usually in hypothyroid patients, you see if the TSH is 3, TSH is 4, below 5, it's okay. So you want to increase the dose as much as possible. Okay. So take TSH up to 1. Okay, without any symptoms, overt symptoms of hyperthyroidism. Yeah. So that is a it is physiological we produce a physiological hyperthyroidism. If there is hyperthyroidism, the TSH falls low. So the TSH is in a lower range, but the patient is physiologically not hyperthyroid. Okay. So he doesn't have tachycardia, he doesn't have start having palpitations or symptoms of hyperthyroidism. Okay, so it is physiological. We produce a physiological hyperthyroid state, all right, which is only TSH is used. Okay, so you keep the max dose that the patient can take. Otherwise, thyroid is a very dangerous disease. Especially even in hypothyroidism, we don't go straightforward. We start with 50, 100. Anything else from anybody? Dr. Aditi, your comments about the seminar?
This is a vast topic, लेकिन आपने बहुत अच्छा किया है. You have touched on this one.
So I think both the presentation important from examination point of view. Long question like biological theories of depression or psychological theories of depression is a question that you have to prepare for it. So the way you did it, you should know the names of all and you should know few in detail. All right. That's it. So I think you should share this PPT with your colleagues and this is something that you will need to know. You must know. Okay, for this is a must know topic. Biological theories and psychological theories of depression. You have to know this if you go